Neurology Quiz number 27. What is posterior ischemic optic neuropathy? This is an acute optic neuropathy due to ischemia of the posterior or retrobulbar portion of the optic nerve, which is supplied only by the pial vascular plexus. It accounts for just 10% of optic nerve ischemia cases compared to its counterpart anterior ischemic optic neuropathy. It is of three types: arteritic, which is secondary to giant cell arteritis; non-arteritic, related to vascular risk factors such as diabetes and hypertension; and lastly, perioperative. This type is most commonly due to spinal surgery. Risk factors in spinal surgery include blood loss, induced hypotension, placing the patient in a prone position, and using facial support frame, example Wilson frame, which increases intraocular pressure, as well as prolonged surgery. Obesity and male sex also increase risk. Association with radical neck dissection and bilateral lung transplant has been described. It is characterized by acute painless vision loss in one or both eyes, which occurs over hours but can progress over days. Perioperative cases tend to be younger and have profound postoperative bilateral visual loss and worse outcomes. Period. In contrast to AION, no disc swelling is noted acutely, but optic atrophy develops 6 to 8 weeks later. The arteritic type is treated with corticosteroids, which may also be an option in the non-arteritic type, although there is no clear evidence that they are helpful. Currently, there are no established treatment options for the perioperative type. There are reports of corticosteroids plus hyperbaric oxygen treatment being helpful. Prevention is more important in this type and consists of avoiding hypotension during surgery, minimizing blood loss, correcting anemia, and positioning the head neutral or higher than the rest of the body to avoid direct pressure on the eye. These images show the blood supply of the optic nerve in the retina. In image 1 is seen the ophthalmic artery arising from the internal carotid artery, which gives rise to the central artery of the retina. The central artery of the retina passes through the optic nerve and supplies the retina and its layers. In image 2 is seen the posterior ciliary artery or the long posterior ciliary arteries, which supply the optic nerve itself. Image 3 shows small PL arteries which arise from the posterior ciliary artery, and these supply the posterior part of the optic nerve. Image 4 shows small anastomotic arteries known as the short posterior ciliary arteries, which supply the anterior part of the optic nerve. As seen in image 5, anterior ischemic optic neuropathy involves the anterior part of the optic nerve, and disc swelling can be seen acutely on fundus examination. As seen in image 6, posterior ischemic optic neuropathy involves the posterior part of the optic nerve, and no disc changes are seen acutely, but optic atrophy develops 6 to 8 weeks later. What are the uses, side effects, and dosages of Lacosamide or Vimpat? Lacosamide is indicated as monotherapy and adjunctive therapy for focal seizures without secondary generalization. It does not exacerbate myoclonic or absence seizures. Oral formulations include tablets and a solution containing 10 mg per ml. An intravenous injection is also available. The parenteral formulation is indicated as short-term replacement when oral intake is not feasible, and is also used off-label in treating status epilepticus. Its mechanism of action is by blocking sodium channels, enhancing slow inactivation, in contrast to most sodium channel blockers, which enhance fast sodium channel inactivation. Oral bioavailability is almost 100%, and protein binding is not clinically significant. Half-life is about 13 hours, and time to steady state is 2 to 3 days. Tmax is 1 to 2 hours. It is metabolized in the liver by demethylation to O-desmethyl lacosamide. 40% of an administered dose is excreted unchanged in the urine. It is secreted into the saliva, and concentrations are similar to unbound levels in plasma. Carbamazepine, phenobarbital, and phenytoin can increase clearance of lacosamide and decrease its levels. Lacosamide does not affect metabolism of oral contraceptives. The starting dose is 100 mg a day, once at bedtime or in 2 divided doses for 1 week, and then 100 milligrams twice a day. Dose can be titrated upwards by 100 milligrams every 1 to 2 weeks until seizures are controlled, side effects appear, or a maximum dose of 600 milligrams a day is reached. Therapeutic levels range from 1 to 10 micrograms per ml. The IV dose for status epilepticus is a loading dose of 200 to 400 milligrams, followed by maintenance dose of 100 to 200 milligrams Q12. Common side effects are headache, dizziness, ataxia, diplopia, drowsiness, nausea, vomiting, and fatigue, as well as depression. Side effects are more common at higher doses and when used in combination with other sodium channel blockers. Serious side effects include prolongation of the PR interval. Patients with known second or third degree AV block may be at risk for severe bradycardia or syncope. It should be used with caution with other medications, including AEDs such as carbamazepine and lamotrigine, that can prolong the PR interval. Lacosamide undergoes partial metabolism in the liver, and lower doses may be required with hepatic impairment. Severe renal impairment with creatinine clearance less than 30 can increase levels, and maximum daily dose of 250 milligrams per day is recommended. The drug can be removed by hemodialysis, and patients may require supplemental doses after the procedure. As compared to other AEDs, lacosamide is associated with a lower risk of major malformations. It is not known whether the medication is excreted into the breast milk. Infants should be monitored for possible adverse effects, and if observed, breastfeeding should be discontinued.